Dear Professor George, our journal is honored by you accepting this interview. The first question regards a letter that you and I, with a group of eminent colleagues, have recently published in the Journal of Hepatology. And our letter has received the response, an editorial graciously written by Professor Angeli, who is the editor-in-chief of Journal of Hepatology. So the question is, why do you believe that there is such a strong interest in naming diseases? Probably in the past, NASH would have simply been alluded to as Ludwig disease.
Thanks very much, Amedeo, for inviting me for this interview and chat. And I look forward to an engaging discussion. I think everyone recognizes that it's crucial to name a disease. However, it's also important to remember that researchers are but a tiny fraction of individuals that use the name of a disease. The vast majority of people that use the name are patients and their carers. And these patients and their carers vary greatly in their health literacy, particularly if you think about it in a global context. So to me, the most important attribute of a name is to be able to communicate the message to patients. And we need to also easily communicate to practitioners and policymakers and the general public to increase advocacy in the context of very limited health budgets all over the world. There are some attributes that I thought of that are important for an ideal name, of course. And to me, the important attributes of a name should be, it should be accurate. So terms that accurately reflect the current scientific understanding of a disease are more appropriate than an inaccurate term. The term's got to be objective. In other words, it should avoid subjective interpretations or value judgments. It should be accessible, by which I mean it should be clear and understandable for health professionals and the general public. And finally, ideally, it should have international applicability, by which I mean that the nomenclature should be used and usable across different countries and languages. So disease names are very, very critical to communicate to patients, and there are some attributes of good disease names as opposed to less good disease names.
Thank you, Jacob. The second question, NAFLD undoubtedly remains the most used among the various nomenclatures to designate the metabolic fatty liver syndromes. However, other nomenclatures have been coined over time, with MAFLD meeting universal consensus, and more recently, MASLD seemingly generating some controversy. In your opinion, which among NAFLD, MAFLD, MASLD captures best the identity of the metabolic fatty liver syndromes, or are we still far from the ultimate definition?
Interesting question, Amedeo. And I agree that currently the field is in a state of flux, with several terms that have been introduced to describe the common liver disease we see. It's been called NAFLD, MASLD, and MAFLD. Are we still far from the ultimate term? I think knowledge evolves, and I would not be bold enough to predict the future. However, what I can say is that MAFLD, MAFLD, is an excellent term for the disease that we commonly see. I say this because it effectively communicates the disease to patients across the world and in all contexts. It is accurate, it is objective, it is easily accessible, and it is internationally applicable. Very importantly, in the context of this whole debate, I think we need to pause and reflect that MAFLD, when it was first introduced, was a real advance for the field. It wasn't just a politically correct term for NAFLD. And the nice thing about MAFLD is that apart from the name, it came with a classification that grew out of an extensive review of the existing literature. As you know, and most of our readers will know, subsequent research has confirmed the utility of the classification for patient management, for understanding baseline characteristics, for defining patient clinical trajectories, and to define patient outcomes. So it's actually conceptually novel. In contrast, in my view, the rationale for MASLD is actually weak. It is not based on an overarching rationale for a new term stemming from some deficiencies of the MAFLD term, but it was more arose out of a need to come up with another term for NAFLD that is more acceptable and a desire to have consensus, which I must say, as we all know, it hasn't achieved. So MAFLD does not represent a conceptual advance, but more of the same. And I think subsequent research has shown that MAFLD identifies patients better than MASLD. So I think to elaborate a little bit more, what NAFLD tells us is what the disease is not, and not what the disease is. In contrast, MAFLD tells us what the disease is and links it to pathophysiology. I think the MAFLD term appropriately has no link to alcohol, as we are trying to define this disease, and I underline the word this metabolic disease, what is it? And that disease has nothing to do with any other disease. So for example, the hepatitis C definition or the hepatitis B definition makes no mention of alcohol or metabolic dysfunction or PBC. It's a standalone entity. MAFLD is a standalone entity that's unrelated to any other disease. And MAFLD, because of its term, aligns in a very holistic way with other associated diseases such as diabetes, chronic kidney disease, vascular disease, and OSA. Unfortunately, in my view, the raison d'etre for so-called consensus, MASLD does not represent a conceptual advance, and problematically for me, it's a mix of positive criteria. In other words, you need metabolic risk factors, and it's got negative criteria. It's got alcohol limits. So it does not define the disease per se. It defines a hodgepodge based on positive and negative criteria. Additionally, I believe that there are some glaring issues with the MASLD definition. If you look at the criteria, it implies, for example, that if your ethanol consumption is more than 50 grams in a female and more than 60 grams in a male, then fatty liver disease, MAFLD, does not have a role in the disease in that patient. We all know that if you've got sufficient metabolic dysfunction, the two will act synergistically together. Secondly, the MASLD, MASLD definition is flawed for less than 5-year-olds. And MASLD suggests that a lot of patients under 5 will have the disease, when we know that that's not true. And the last problem with MASLD is that it maintains the heterogeneity that we have for NAFLD. So it's exactly replacing one term with the other, when we know that, those with overweight and obesity, those with type 2 diabetes, and those who are lean have distinct baseline characteristics, distinct clinical trajectories, and distinct clinical outcomes. Because of all of this and thinking about it deeply, I do believe that MAFLD is a much better and more appropriate term.
Thank you. The third question is, it may be argued that, inverted commas, science does not follow the methods of democracy. Does this imply that we should do without Delphi conferences in future? What do you think?
Amedeo, this is a very interesting and a very important question. Let me at the outset say that fortunately, science is not democratic, and human consensus is irrelevant to science. We cannot consensus our way into stating that the sun revolves around the earth. Science tells us it is the other way around. So when we talk about democracy in science, I believe that it implies in relation to scientific processes and data, and that the scientific process should be transparent, should be open to scrutiny, and the ultimate outcome is based on a very rigorous process of adhering to the principles of testing, evidence gathering, peer review, and most importantly, replication of the data. So this brings me to the role of the Delphi process or Delphi processes. I think the fundamental role of a Delphi process is to come to consensus on existing evidence, if there is conflicting evidence. So in a field where there's articles that say one thing versus the other, and there's a conflict, you can resolve the conflict for the short term until we get more evidence with consensus. But the role of a Delphi is not to come to a consensus on a completely new disease terminology. That's like picking something out of there and saying, this is what we're going to call it. That's not what a Delphi is all about. The beauty of science lies in the freedom to use terms that best reflects current understanding of the disease. And I think the Delphi process in this instance has really been hijacked for a reason that it wasn't meant to be.
Thank you, Jacob. Let us now move to the next question. It's a hot topic, stigma and stigmatization. When dealing with these themes, one should always consider that non-alcoholic negates rather than emphasizing a given etiology of liver disease, and that what may sound as stigmatization in certain cultures, e.g. the adjective fatty, may be a synonym of healthy and prosperous in many others. How do you feel that can these cross-cultural differences be resolved in the scientific arena?
Great question, Amedeo. It does bring us to the important issue of stigma and of cross-cultural differences. What you say is entirely correct. However, in this debate, there is an even bigger issue. Let us for a moment agree with the notion that stating that someone is fat is stigmatizing. Does Maffel refer to the person as fat, or to the fact that there is fat in his or her liver? That's a fundamental difference. How does referring to an internal organ, which is not visible, be considered stigmatizing? Should we talk about fatty streaks in atheroma as steatotic streaks? Should we talk to patients about atheromatous disease in terms of steatosis of the blood vessels? Or should we, for that matter, change the term visceral fat to visceral steatosis, or fatty pancreas to steatosis of the pancreas? And I think, as elegantly published in a paper a couple of years ago by a colleague, he stated that fatty liver is not the term to say that fatty liver is stigmatizing is based on a conceptually flawed premise that the word fatty is stigmatizing even when it refers to an internal organ. And I think that's the problem with this so-called stigmatizing aspect. Above and beyond this, only a minority of patients, if any, average patient, understands the word steatosis. And I was at a recent meeting 2 weeks ago, and when we asked the audience, after you tell the patient that they have MASLD or steatotic liver disease, we said, what do you then talk to the patient about? And all of them unanimously said, we automatically, invariably revert to fatty liver to explain the disease to the person sitting at the other end of the consultation couch. So fatty, when it refers to an organ, I don't believe is stigmatizing. In addition, as you correctly point out, there is no distinction between fat and steatosis. In most languages, in this era, we want a global term.
Thank you. Let us now move to the next question, which may be too far-fetched. I want to know your opinion. The book entitled Destined Destined for War by Graham Allison addressed the question of how an established power and a rising power can avoid collision and military conflict. Do you believe that this book has anything to do with scientific controversy, if not acrimony, that we are presently witnessing in the arena of the muffled nomenclatures?
Amedeo, yes, this is a very interesting point, and I have read the book. As it states, and the central thesis of the book is that when there is an existing power and an emerging power, there are immense structural stresses that happen, and that threatens the established order. And it can and frequently does result in conflict. However, there is no way to avoid the fact that today's world is now a global world, and it's changing with new centers of research, new drivers of economic progress, new drivers of social and philosophical thought, and continuous cultural evolution. I think done thoughtfully, as stated in Destined for War, and if people have a willingness and an attitude to engage, seeing and recognizing different perspectives and having mutual respect, I think there is room for all views for the benefit and progress of all. I think attempts to stifle innovative thought and innovative conceptual advances never works in the long term.
Thank you very much, Jacob. Next question is eminence versus evidence. How would you suggest addressing the above-mentioned controversies? On the one hand, one might aim at edification of a global hepatological society aimed at avoiding single nation or continental scientific societies lead the way at the disadvantage of excluded countries, which, however, often are home to prestigious scientific leaders. On the other hand, one might simply rely on scientific data and the experimental method.
Interesting question, and I did read that paper on eminence versus evidence, Amedeo. In my view, there can only be one way forward, and that, as we discussed, is through the scientific method, evidence gathering, and comparing the utility of various terms for clinical care. But to really move forward, after we gather the evidence, we have to be open in our minds. We need to be willing to engage and willing to change. But all of this is actually based on a foundation of mutual respect. People all over the world in different countries and continents, they're different. We look different, we eat differently, we dress differently. And I think, now is the time where we should show mutual respect. And really, as long as it's based on evidence gathering and advancing the field, that is the only way forward for us.
Thank you very much, Jacob. Next question is, clearly, if a given national continental scientific society, irrespective of how prestigious it may be, enforces the utilization of a given disease nomenclature, how can comparative studies be conducted? Could this attitude be a concern for the advancement of science?
Absolutely, Amedeo, and exactly as you infer, this is a very major concern. Enforcement can work in the short term, but is unscientific, undemocratic, and demonstrates, in my view, a lack of mutual respect. The real victim of this is scientific progress and earlier improvements to patient care. What we need desperately in our field of hepatology are comparative studies, even though the results may not be what we want to hear. But that is science. It is based on evidence. Stifling it only delays progress. And there was another recent book called The Ulcer Wars, and it illustrates very clearly that we understood the role of H. pylori in peptic ulcer disease about 15 years before it was accepted by certain places in the world, and it delayed access to treatment of very permanent H. pylori eradication therapy for more than a decade, nearly 2 decades, because people were really not willing to look at the evidence and look at the data. So we must really stick to the scientific principles.
Many thanks, Jacob. The last question is, as many of us are retiring or retired researchers, it seems to me that younger generations of investigators seemingly want to mark this generational change by establishing a novel disease nomenclature. Do you have any suggestions for younger hepatologists?
I think, Amedeo, the nice thing about the human journey is that we all have our day in the sun. Life is ever changing, and it's good that younger generations will take the baton, as after all, it will be them that shapes their future and the world in which they're going to be major players. I think for young hepatologists, I would simply say, enjoy the journey. Keep an open mind, true to the scientific process, but most of all, enjoy the journey. And the journey is the purpose of life. Thank you.
Thank you. Thank you. Thank you so much.